Welcome to webcast 5 from San Antonio. This afternoon we're going to be talking about ovarian suppression on a background of tamoxifen, and two important papers were presented this afternoon. And with me I've got Ian McPherson and Marina Parton, both medical oncologists. They're going to present the data and then we're going to have a roundtable discussion about the implications. So Marina, I think you're starting. Off you go. Thanks, Richard.
So I'd just like to introduce the initial presentation by Prue Francis on behalf of the SABCS and other collaborators. The study looked at the randomised comparison of adjuvant tamoxifen plus ovarian function suppression versus tamoxifen alone in premenopausal women with hormone-positive early breast cancer. We know from previous experience and previous data that premenopausal hormone-positive early breast cancer is best treated with adjuvant tamoxifen for at least 5 years in young women. That chemotherapy-induced amenorrhea has a reduced risk of relapse. And it's been uncertain for some time whether the addition of ovarian function suppression to tamoxifen gives added benefit. There is evidence to suggest that women under the age of 35 years of age have an increased risk of relapse despite chemotherapy and tamoxifen being given, and this may be due to return of menstrual function. So this study originally set out to answer, what's the value of adding ovarian suppression to adjuvant tamoxifen in premenopausal women? And is it possible that the addition of an aromatase inhibitor to ovarian suppression in lieu of tamoxifen gives greater benefit? So the overall schema of the SOFT study involved women being split up into two initial cohorts. Women who received no chemotherapy and went straight on to endocrine treatment, and women who received chemotherapy and then, several months later, went on to endocrine treatment. Women are randomised to tamoxifen alone for 5 years, tamoxifen plus ovarian suppression for 5 years, and the ovarian suppression could be biochemical with monthly triptorelin injections, or it could be permanent ovarian ablation. Women were also randomised to exemestane plus ovarian ablation. The premenopausal status of women were determined, particularly after chemotherapy, with estradiol levels, and this could be checked up to 8 months after completing chemotherapy, although women had already started tamoxifen. The protocol endpoints were primarily disease-free survival, and secondary endpoints were breast cancer-free interval and distant recurrence-free interval. A protocol amendment was required in 2011 due to the good outcome seen in all the treatment arms, and therefore there was a revision from the original plan for the 3 pairwise comparison. The primary analysis became a comparison between tamoxifen and ovarian suppression versus tamoxifen alone. At the time of analysis in this presentation, the median follow-up was at least 5 years. And as stated before, the analysis was split up in 2 cohorts, women who received chemotherapy and women who did not. The comparison between tamoxifen and ovarian suppression and the aromatase inhibitor exemestane became a secondary objective.
Thank you, Marina. So let's first look at the characteristics of the patients enrolled into this study. And as previously stated, there are 2 cohorts, approximately half and half, who had either received chemotherapy or had not received prior chemotherapy. And this was obviously at physician's choice, so as you would expect, the baseline characteristics are really quite different in these 2 groups. So for those women who had received chemotherapy, they tended to be younger with a median age of 40. They were more likely to be lymph node positive, so 57% of the chemotherapy cohort were lymph node positive compared to only 9% of those patients who did not receive chemotherapy. The tumours were larger and were more commonly grade 3 and more commonly HER2 positive. So this slide shows the primary endpoint, disease-free survival, for the entire cohort, both chemotherapy and non-chemotherapy patients. And this shows really no significant advantage for the addition of ovarian function suppression to tamoxifen. Moving now to the secondary objectives, and specifically the comparison of exemestane and ovarian function suppression versus tamoxifen. And here there was a significant improvement in favour of exemestane and ovarian function suppression, with an improvement in the absolute number of events from 84.7% to 89%, giving a hazard ratio of 0.68. Moving now to the two cohorts independently. So first, the no chemotherapy cohort. And the key point to remember here is that this group, by their very nature, was a very low-risk group. They were older than 40, primarily node negative, 40% grade 1. And so here the outcome was really very good across all three arms, and no benefit was seen for the addition of ovarian suppression to tamoxifen. However, moving to the higher risk chemotherapy cohort, here an absolute improvement in 5-year breast cancer-free interval was observed in favour of tamoxifen and ovarian function suppression versus tamoxifen alone. This was of the magnitude of 4.5% in absolute terms. The secondary comparison then of exemestane and ovarian function suppression versus tamoxifen was associated with a still greater improvement, an improvement in 5-year breast cancer-free interval of 7.7% and an improvement in the 5-year distant recurrence-free interval of 4.2%. Finally, they also performed an analysis according to age. Here, the group of women aged less than 35 years, and these are the women that we know have a worse outcome. And here the magnitude of benefit for ovarian function suppression was really significantly greater. And again, this was more marked for the combination of exemestane with ovarian function suppression in comparison to tamoxifen and ovarian function suppression. So we'll move now on to the adverse events and quality of life data that were also presented. So it was very clear that the addition of ovarian function suppression increased menopausal symptoms, depression, hypertension, diabetes, and also the risk of osteoporosis. Looking then at the difference between exemestane versus tamoxifen, both with ovarian function suppression, it was clear that exemestane had a greater detriment on sexual functioning and caused more vaginal dryness. In addition, there were more sleep problems with exemestane. Now, in terms of adverse events and quality of life, it was clear that the addition of ovarian suppression increased menopausal symptoms, depression, hypertension, diabetes, and osteoporosis in both the tamoxifen and exemestane arms. However, there were differences between tamoxifen and exemestane in conjunction with ovarian suppression. Specifically, patients on exemestane reported more musculoskeletal symptoms. They had more loss of sexual interest and vaginal dryness, and also more sleep problems. Conversely, those patients receiving tamoxifen and ovarian suppression had a higher incidence of hot flushes and vasculomotor symptoms. There was no difference in reported weight gain between arms. So in conclusion then, for the overall premenopausal population, there's no benefit in adding ovarian function suppression. And we do need to remember that even within these very young patients, some will do very well with tamoxifen alone. For those women, however, at higher risk, and a surrogate of that in this trial is those women who received adjuvant chemotherapy and who remained premenopausal following their chemotherapy, then addition of ovarian function suppression did appear to reduce the risk of recurrence. And this was evident with tamoxifen, but was more marked when ovarian function suppression was combined with exemestane. And perhaps the most striking benefit was seen in those women under the age of 35.
Right, so here we are, we've got results. Is this the final nail in the coffin of ovarian suppression, or is this a game changer? What are you going to do when you go home?
Well, I think it was really fantastic to see these data today, because we've been waiting for this information for a long time, actually. And this is a really relevant clinical question. So I think there are various things which we need to consider, and as always with our adjuvant treatments, we need to consider an individual patient's risk. So how much do they stand to benefit from any intervention, obviously weighed against the toxicity. And I think it's quite clear that in the entire population, premenopausal population, we should not be adding in ovarian function suppression on the basis of these data. The question, though, is whether there are subgroups where the benefit is greater. And clearly those women at higher risk of relapse, here the women in the chemotherapy cohort, there is space there for a further intervention such as ovarian suppression to improve outcomes. That's just not possible in a woman with a low risk already of relapse. The very interesting thing here is the seemingly greater effect in those very young women.
And certainly, I think with the previous analyses where the benefit of ovarian suppression or amenorrhea was displayed, we always had a doubt that tamoxifen alone was sufficient for those high-risk women. And it's interesting that this data is probably the largest collection of women who have been prospectively randomised in this manner, where we've got clear evidence of premenopausal status before they started ovarian suppression. So we know that they were truly premenopausal, and they were displaying the benefit.
So we can not park, but we can continue to treat our slightly older, low-risk premenopausal patients with tamoxifen alone. Would you go as far as to say that all of our under 35s now that this should be considered? I mean, those figures look quite compelling, that the addition of the aromatase inhibitor to ovarian function suppression did seem to give a benefit, and the benefit for exemestane was 50% higher than it was for tamoxifen, which fits with the other sort of aromatase information we have over the years, 50% reduction on top of tamoxifen for contralateral disease, for instance. So it feels to be in the right ballpark figure. Or do you think the toxicities are too much?
Well, I think it should definitely be discussed with a patient. I think it's one of the strategies that we should use in younger women. I think I would, as I do at this time, is phase in the tamoxifen and the ovarian suppression, and depending on toxicity, if it is tolerable, ovarian suppression is something that women can do at a younger age, but may not be able to do for the full 5 years.
So would you start with tamoxifen, then ovarian suppression, and if they're tolerating that, switch to an aromatase inhibitor?
Possibly, possibly. My first gut instinct is to carry on with tamoxifen and ovarian suppression in the first place. But with the data, particularly from the text and subgroup soft analysis from earlier this year, I think with very high-risk women who are keen to garner or benefit in endocrine therapy, the aromatase inhibitor question has to be explored.
And side effects?
The side effects with global quality of life assessments appear to peter out the longer the women were on treatment. I'm not sure that's a real reflection of what's happening. If we eke out the endocrine symptoms, those are still being reported in high levels. Whether women just give up or are not taking all their treatment, I don't know.
Well, it's interesting. I found it fascinating that such a high proportion was still managing to tolerate their ovarian suppression at 4 years. And whether that's a reflection that it's actually administered to them by someone else, so it's less easy to escape it because they're pinned down and presumably have an intramuscular injection. We weren't told the figures of how many received triptolin, were we, or was it about 80%?
80% of women
had triptolin. Obviously, with a permanent ablation, it's going to be permanent. But I thought that was quite a high compliance figure.
No, I was quite impressed with that as well. But we don't know the data regarding tamoxifen aromatase inhibitor compliance. And I think particularly with the aromatase inhibitors, my main concern would be with the myalgia, vaginal dryness, really significant day-to-day problems that women were actually taking that drug in addition.
And the other thing is we don't know about the osteoporosis incidence. They mention it, but they don't mention bisphosphonate usage. And we know from earlier studies where goserelin was used with anastrozole that it really did affect bone mineral density in a big way, and that this group needed careful monitoring of their bone mineral density, and quite a few of them became osteoporotic in that original Austrian study, so that we need that information. There was an additional poster yesterday on the soft side effects, looking at these cerebral effects and showing no benefit or no loss on brain function, which I think is reassuring, but again, that wasn't completely explored or clear which tests they'd use, but that again is reassuring.
And also it's quite short term, it's a year, wasn't it? It was a year. So many women would have been actually recovering from chemotherapy, would be recovering from many of the effects of the initial treatment. So I'm not sure how accurate that will be, I think in the 2-year, 4-year mark. I think we may see some additional changes. And certainly women report when they have estrogen deprivation, multitasking, short-term memory problems. That's a very common reported symptom. So I'm surprised that didn't come out, but we'll wait and see.
Okay, thank you. So Ian, this has been an interesting discussion. Can we put ovarian function suppression to bed? Do we ever need to do another trial of 3,000 women with or without ovarian function suppression?
I think whether we need to do a trial or not is a good question. I don't think a trial's ever going to happen like this again. That's the key thing. Actually, I think we still have quite a lot to learn from this trial. So actually, for an ER-positive adjuvant study, the follow-up is short. We're seeing these benefits now, which seem to be of a reasonable order of magnitude. And based on what we know from a typical pattern with ER-positive adjuvant studies, these hopefully will grow with time and we'll see an even greater magnitude of benefit. I mean, I guess one thing is the kind of translational side of this study. And really, what we are lacking are markers that would really allow us accurately to select which patients do benefit from ovarian function suppression, and in that case, which ones benefit from the addition of TAM or the more toxic aromatase inhibitor. And whether blocks are available for this study and there's a translational component, I actually don't know.
Yes, there are. Yeah.
Great. So I think there's a lot to be learned from this study still.